Welcome back to On Health. I'm Dr. Bob. Today's episode, we're going to talk about weight loss surgery. It's part two of a three-part series. We started the series talking about recently approved medications for weight loss, Ozempic and Mounjaro. Mounjaro is not FDA approved for weight loss yet, but it likely will be based on recent studies. Today we're shifting the focus to surgery for weight loss, or what we call bariatric surgery. The term bariatric is a relatively new term. 1961, the term was coined by a group of weight loss surgeons to represent weight loss surgery. So we call it now bariatric surgery. In the United States, over 200,000 weight loss surgeries are performed per year for obesity of various stages. And let's talk about that first before we go any further, because I consider weight loss surgery the last resort. The risks are higher than they are with medication or diet or exercise. And because of the risk and the benefit, we have to consider it to be the last resort. So for that reason, I only recommend bariatric surgery for patients that are in the moderate to severe obesity categories. It causes me great concern when I see people electing to have weight loss surgery or bariatric surgery when they don't fall in those two categories. To review that, and I'll use myself as an example, I'm about 5 feet 8 inches tall and I weigh about 170 pounds, and that would give me a BMI or body mass index of 26. 26 puts me in an overweight category, and I would not ever consider myself a candidate for bariatric surgery based on that. The next category is after BMI of 25 to 30 being overweight, is a BMI of 30 to 35 being class 1 obesity. And then from 30 to 35, from 35 to 40 is class 2 obesity, and a BMI over 40 is morbid obesity or class 3 obesity. And I only consider patients in class 2 with complications or class 3 without complications to be really good, the best candidates for bariatric surgery based on the risk versus the benefit, like we do everything in healthcare. I mentioned complications associated with obesity, and there's a variety of complications associated with obesity. Type 2 diabetes, respiratory problems including obstructive sleep apnea, cardiac complications, mental health complications associated with obesity, and gastroesophageal reflux disease are some of the more common ones. Clearly, blood pressure responds to weight loss, and a variety of other healthcare concerns that are associated with obesity can improve with weight loss. So once again, just to reiterate, I think you're only a candidate or a best candidate for bariatric surgery if you fall into a category 2 or class 2 or class 3 obesity, meaning a BMI of 35 to 40 or a BMI over 40. And there's BMI calculators that you can find online. I recommend plugging in your height and weight and see which category you fit in. They're fairly broad categories. The normal category for my height and weight runs from 120 to 165 being called normal weight. Less than 125 would be underweight, and there's categories of that as well. Now let's focus on individual weight loss procedures. And weight loss procedures have been done for many years. They've evolved over time. They've gotten significantly safer. I mentioned risk versus benefit. The complication rate with obesity surgery or bariatric surgery used to be in the 11% range, and it's come down to about 1.4% in some of the more recent studies, with a morbidity, a mortality, death rate associated with the operation of 0.04%. In some of the more recent studies. And that means that there's a 4 in 10,000 chance that if you undergo weight loss surgery, you may not survive the surgery. And there's about a 1 to 1.5% chance that you'll have a significant complication associated with that surgery. And just to go back, that's why I don't recommend them unless the benefit far outweighs the risk associated with the procedure. When we talk about bariatric procedures, they fall into three categories, and having said that, there's a great deal of overlap between those three categories. The first category is what we call a volume restrictive category, and this is procedures that either cause the stomach to be smaller or cause it to feel smaller, leading to early appetite loss and early feeling of fullness. The second category of bariatric procedures falls into a category that we'll call malabsorptive, meaning it reduces your body's ability to absorb nutrition in the intestinal tract. And then a third category of bariatric procedures is focused primarily on changing the hormone status of the body to make it less, to suppress appetite and to make it less apt to absorb nutrients that are passing through the intestinal tract. And we talked about that a little bit with the medications because they work in many of the same ways. The GLP-1 and GIP agonists that trigger those receptors cause appetite loss, cause early satiety or early feeling of fullness. The surgical procedures also do that in a more mechanical way. So let's talk about the current number one bariatric procedure in the United States. Over 80% currently of bariatric surgery consists of vertical sleeve gastrectomy. A vertical sleeve gastrectomy is partly a volume restrictive procedure because we're getting rid of 75 to 85% of the stomach. The stomach is a large sac meant to hold food. First stages of digestion take place there. There's mixing with acid and digestive enzymes in the stomach. But with this procedure, we eliminate 75 to 85% of the volume of the stomach. That makes the stomach feel full very, very quickly. There's a small upper pouch that fills up. It's typically 30 milliliters, a small glass of water size would fill that sac and cause a feeling of gastric fullness or the sensation of fullness and early loss of appetite. But there's also other components to this. In addition to turning the stomach from a sac into a tube, we're also eliminating part of the stomach that releases a hormone called ghrelin. Ghrelin is a hormone that when present causes hunger to some degree, and when absent causes loss of appetite. And because the stomach is a source of ghrelin, when we take out 75 to 85% of the stomach, there's less of that hormone present, hence loss of appetite. So there's a volume restrictive component to it, there's a hormone component to it, and possibly there's a malnutrient component to it because there's a little quicker emptying of the stomach because of its sheer size, leading to faster transit times, and the faster transit times are the less time there is for nutrient absorption. But if at all, that's probably a very minor component of that operation. The reality is it's very commonly done. It's considered a very safe operation. When there are complications, the complications can come from the staple line where we remove the 75 to 85% of the stomach. And when those complications occur, they can be very severe. And I don't want to undersell that point. Even though it's the most commonly done operation and 99% of the time there are no complications associated with the procedure, the 1% of the time when there are complications, they can be severe. The procedure is effective. It results in a 75 to 85% excess weight loss over 2 years' time, which is incredible. The best that we're seeing with the medication trials is in the range of 30% excess weight loss, although those trials are early for the newer drugs and haven't gone out to the 2-year mark to my knowledge. So it's hard to compare apples with oranges, but this surgery is dramatically effective, and it's dramatically effective in eliminating or reducing the complications associated with obesity. Patients that are type 2 diabetic sometimes can come off medications. Patients that are hypertensive sometimes can come off their antihypertensive medications. Joints last longer. Gastroesophageal reflux disease can improve, although let me point out there that a vertical gastric sleeve operation is probably not the best operation for someone with severe reflux, because that narrowed tube of a stomach actually can worsen reflux into the esophagus. So there are other operations that might be better suited for that particular purpose. The mental health benefits are obvious. We've talked before about obesity having mental health causes and effects. And for a lot of people, it can significantly impact depression and other mental health concerns. Sleep apnea is dramatically better after weight loss. I'm a vascular surgeon, and vein-associated problems, venous congestion, varicose veins, blood clots, DVT blood clots, and pulmonary embolism are significantly lower in non-obese patients. So there's a lot of reasons that it's actually a very good operation when it's needed. The second most common bariatric surgery in the United States, accounting for roughly 20% of procedures currently, is called a Roux-en-Y gastric bypass. This one's a little more difficult to explain. It's a combination procedure, and the reality is, like the other that we discussed, is there's components of all three. There's a little bit of volume restrictive, there's a significant component of malabsorptive, and there's clearly a component of hormone altering, intestinal hormone altering effect from the procedure. And we'll show a diagram. With a Roux-en-Y gastric bypass, a segment of the small bowel is brought up to a small residual stump of the stomach. There's the restrictive component to it. That small volume stomach causes that sensation of early fullness and loss of appetite. But then from there on, it actually is more of a nutrient to malabsorptive operation. And the reason is it causes very rapid transit of nutrients through a shorter segment of small bowel. And the small bowel is where most of nutrient absorption takes place. And by shortening that length of small bowel, we're passing things through very quickly, and that's good and bad. It's good because we're passing excess nutrients through in a speedy fashion, but that's also where some of the complications can come in with this procedure. This procedure there's more of an art to this procedure. The length of small bowel that's left in the circuit is there's not a lot of agreement on what the proper length is, and some centers have better success rates than others, and there's more of an operator dependent component to this procedure than the vertical gastric sleeve, and that's probably why it only accounts for about 20%. But having said that, it's markedly effective with class 3 obesity, BMIs over 40, because of the nutrient malabsorptive component. The downside to it is some patients can become micronutrient depleted, and there is a risk of becoming calorie protein depleted as well. And some people overshoot their target weight with this particular procedure. So it is something to consider when considering this operation compared to the vertical gastric sleeve. This operation is a better operation for patients that have severe gastroesophageal reflux or heartburn on a regular basis, or especially if they've been diagnosed with something called Barrett's esophagus, which is a precursor to esophageal cancer caused by reflux. For patients that have that, this results in more rapid emptying of the small residual stomach, and so it won't exacerbate the reflux symptoms in most people. This is different from the vertical sleeve gastrectomy, that can exacerbate reflux symptoms because of the small tubular nature of the stomach, creates more back pressure. There's a small upper sac of the stomach and a small lower sac of the stomach, and there's a significant increase in pressure in that range, and can push things forward, but it can also push things back, resulting in worsening of reflux. So those are the top two operations that account for well over 90% of the operations currently done in the United States. The gastric balloon procedure is approved. There's another procedure that's technically more involved in a longer operation. It is markedly effective for class 3 obesity patients with BMIs well over 40, can be a good option. It's called a biliopancreatic diversion with duodenal switch. And essentially this is a combination again. Primarily I would consider this mostly a nutrient malabsorptive procedure, although clearly there's intestinal hormone altering effects of it. And there's also a smaller component of volume restrictive part of this. It also leaves a small residual stomach that's then connected to a short limb of small bowel that goes directly into the large bowel. And because of this, the length of bowel available for nutrient absorption is remarkably reduced. Again, this can have dramatic effects on weight loss, but it can also cause micronutrient malabsorption. It can cause protein calorie malnutrition if it's overshot. And there's a lot of finesse to this one. And if you have this procedure done, you need to have it done somewhere where they do it routinely with good results. And there's ways to check that out. But you seek a referral to a center that specializes in this procedure if this is the one that you choose, because it is technically more difficult and it's more variable in outcome depending on how it's performed. So those are the top three. The gastric balloon is a rare one, but it is done. There are some places that still do the lap band or the laparoscopic gastric band, adjustable band procedure. But those three operations account for the majority of the bariatric surgery currently being done in the United States. There are two other operations currently done in the United States for weight loss. One of them is called a single anastomosis duodenal ileal bypass, or abbreviated SADI, and it's a little bit of a combination of others where it results in a gastric resection or a partial gastric sleeve, but also with a connection to the small bowel, resulting in rapid transit. And so it has some of the volume restrictive components to it, but also some of the malabsorptive components to it. The final operation I wanted to mention is called a one anastomosis gastric bypass. And this is a simplification or a variation of some of the other procedures. It has some of the components of the vertical sleeve gastrectomy in that we're removing part of the stomach, but it also includes a connection between the stomach and the small bowel, leading to the more rapid transit and the nutrient malabsorptive component, where you're just not absorbing as many nutrients. And again, there's probably a component of the intestinal hormone related weight loss with reduced production of ghrelin, the gastric hormone that can lead to a sensation of fullness or loss of appetite. And that's it for our discussion today of bariatric surgery or weight loss. I mentioned earlier that we're doing this a little bit out of order. We started with medications, which probably should have been number 2. We've done bariatric surgery, which probably should have been number 3, because as I said several times, it's a last resort. The risk versus the benefit has to be there to justify doing surgery to promote weight loss. And that's when the other health effects of obesity are starting to become more of a risk, and we've failed what should have been number 1 episode, diet and exercise. Stay tuned. We'll talk about diet and exercise on our next episodes. Stay healthy, my friends.